Welcome, voice friends, to another episode of Interviews on Voice Matters. My name is Liz Johnson, and today we have Dr. Joseph Stemple with us. He is a speech-language pathologist and a PhD professor at the University of Kentucky College of Health Sciences in the Department of Communication Sciences and Disorders Rehabilitation PhD program. He does quite a bit of research, and the thing that he is most famous for, most known for, are the vocal function exercises that most speech-language pathologists use in voice therapy. So thank you very much for taking the time to talk with us today.
Pleasure, thank you.
Absolutely. So I'm just going to jump right in. How did you get interested in voice?
I think I'm one of the rare examples of somebody that actually became interested in speech-language pathology when I was in high school. Really didn't know anything about the profession, but had been very much involved in choirs and band and theater and musical theater all through high school, and wanted to have something to do, especially with the theater world. Didn't have the guts to go into theater as a major because I was too practical, and my parents directed me to be a practical kind of person. And so I started searching for, how can I have an impact in that world? And we're talking way, way back. We're talking, that would have been, I graduated from high school in 1969. So long time ago, before so many of our music friends decided to become speech-language pathologists and kind of cross-pollinate that way. And so the year before, a new program at the University of Cincinnati in speech-language pathology had opened up. I was living north of Cincinnati and went down for a visit. Was treated like a king down there. Of course, I had no idea that it was a profession that was dominated by women, and they wanted men in the profession, as we do today. And really fell in love with the campus and the program, and that's where I ended up going.
Great. And so once you did your undergrad, what did you do for your master's after that?
I actually got all three of my degrees at the University. They, how can I put this delicately? They kept giving me money, so I kept going. And actually had no intention of getting a PhD. But the more I got into the science and the research, especially of voice and voice disorders, I had Professor Vern Stroud, who really piqued my interest specifically in voice production. They approached me one day and asked if I had ever considered getting a PhD, and had not. They talked to me about it, and I was offered a clinical doctoral fellowship, which basically paid for my PhD program, and I gave 20 hours a week to the University of Cincinnati Medical Center, Department of Otolaryngology, where for the most part, I saw patients with head and neck cancer and some voice disordered patients. Robert Peppard was my first clinical supervisor there, and again, it just was an evolution of an interest in that particular area.
Okay. And I read in one of your papers that you developed the vocal function exercises based on work from the late 50s.
That's right.
By someone named Bryce?
Brees. Mm-hmm.
Brees.
Bertram Brees.
Brees.
Actually, I tell people in presentations all the time, I really didn't develop the vocal function exercises. If we look at the skeletal structure of vocal function exercises, they used to be called Brees exercises. It was sustaining the vowel E for as long as possible, gliding up, gliding down, and holding out 5 different notes on the sound O. Okay, so the skeleton of vocal function exercises was Brees's work. And Brees was of the opinion that the laryngeal musculature are extremely important, obviously, in voice production, and that many voice disorders result as in either a weakness or imbalance or both of the laryngeal musculature. And so he talked about how we need to exercise them and gave the example of, well, it's like physical therapy for the vocal mechanism. Now, some people don't like that analogy, but our patients certainly understand that analogy, and it's not exactly correct, okay? However, what we did, I heard about that exercise program actually soon after graduating with my PhD, and went to a workshop where someone talked about Brees and Brees exercises. And quite honestly, I took the handout from that and put it in the file because I'm thinking, how can this possibly work? You hold out some tones, you do some glides, and people get better. Wasn't quite sold on that. But then one of my first jobs out of practice was with an otolaryngology group, Nathaniel Soifer and Associates in Dayton, Ohio. Probably one of the first private practice otolaryngology groups to hire a speech language pathologist for their voice disorder team. And that would have been, or patients, I should say, that would have been in 1977, I believe. And maybe 78. At any rate, I grew up on a symptomatic approach to voice therapy. If you hear it, change it, if it's inappropriate. And I started seeing 8 to 12 patients a day, as you do in a private practice, and wasn't satisfied with the results that I was getting. It's really hard, in a symptomatic approach. If somebody is speaking with a pitch that's too high, you lower it. If they're breathy, you compress it. Okay, I mean, you react to the symptom. And what I discovered was it is so very difficult for people to think about how they're talking when they talk. Okay, so I would say, okay, so now we have to concentrate on lowering this pitch down to this level. So as you're talking, concentrate on that. Well, you get into your daily routine. How can you think about how you're talking? It's really very difficult. So I was getting a bit frustrated because, quite honestly, no-show and dropout rates were fairly high because people couldn't accomplish what I was asking them to do. Okay. So I decided, okay, I heard about these Brees exercises. Let's try it. And again, it was just simply sustaining O softly, E sound on the first exercise softly. There was no concept of semi-occluded vocal tract. There was no concept of how intense or loud it should be. There was really not a concept of giving people goals for how long they should be able to sustain the tone. I started doing the exercises as Brees described, and interestingly, patients were making progress, and I couldn't figure out exactly why, but I tried to make some justification for it in my mind, and thought that we had something that was missing in our direct therapies and in our symptomatic therapies, and that missing thing was an underlying physiologic exercise program. Something to rebalance, something to rebuild that system that really had nothing to do with speech, but had everything to do with entraining the laryngeal mechanism. Okay. And so started doing them, started having good success, reported some of that success, didn't truly understand and still don't really understand exactly why they do what they do. But started implementing changes based on the research that started coming out after that period of time, over the next 20 to 30 years, actually, with the semi-occluded vocal tract in particular, knowing how long a person should be able to sustain a tone based on lung capacity, and so really molded them into what we call vocal function exercises. I also tell people I didn't make up the name. Okay, so I didn't invent vocal function exercises, nor did I make up the name, because there was one year when Diane Bless from the University of Wisconsin invited me to come talk to her doctoral seminar on voice therapy techniques, where they tried to figure out, why do voice therapy techniques do what they do? Okay, how do they improve a person's voice? So I presented what I called at the time Brees exercises, and Diane made the observation that one of the reasons that brief exercises really didn't go forward from the 1950s till, gosh, now we're into the probably would have been early 1990s by the time I was giving this lecture in Wisconsin. Well, one of the reasons it didn't go forward was if you read Brees's articles, I think they were in Acta Otolaryngology. If you read his articles, he made some significant mistakes in describing laryngeal muscle function. And so I describe it like this: the baby was thrown out with the bathwater, okay? And so it didn't go forward. All right, and until we started doing some of the research on it. So I guess it wasn't until the early 1990s that I actually started doing outcome studies with vocal function exercises, though I had been using them for probably 15 years by that point, and lecturing on them and describing to people how to do them and all of that. So it's not unusual for us to put the cart before the horse. We do things that work without necessarily knowing why they work. Okay.
Mm-hmm. Mm-hmm.
There now have been 29 outcome studies that demonstrate vocal function exercises do something positive for the voice. But I still don't know exactly what the active ingredients of the exercise happen to be. So we're actually doing a series of studies right now. We've completed 4 of them. 2 of them are published. One of them has been submitted for publication, and the final one is ready for submission, where we actually are dismantling the exercise program, okay? Do we truly have to sustain the tone for as long as possible? Well, we're finding out, yeah, you do, okay? Is the semi-occluded vocal tract that we use in the buzz that we use in vocal function exercises, is it necessary? Yes, it is. Do we have to give people a specific goal? Okay, will they attain better if they have a goal for how long they should be able to sustain a tone? Yes, you do. Okay.
Wow.
Do they have to do it 2 times each, 2 times a day, or can they do it more? Can they do it less? They can't do it less. They can do it more. However, more takes longer and more people drop out. Okay.
I was going to ask you about that.
Each 2 times a day takes about 8 or 10 minutes in the morning, 8 or 10 minutes in the evening. That seems to be an optimum amount to do it. So we have other things that we're going to do to dismantle them to see what's important and what's not, so we can take them down to the bare bones, precisely what has to happen. Is there any fluff in the exercise program? Can we make it simpler for people? For example, on the semi-occluded vocal tract concept of that O buzz that we do, that is difficult for some people. Can we do an O? Well, an O is a semi-occlusion as well. It almost met significance in pre and post, okay, as the old buzz did meet significance in pre and post. So, you know, for somebody who just simply can't get that really good kind of sound, is almost as good. Okay, so these are the things that we're finding out as to what can be done, what are the ingredients that are absolutely necessary in the exercise program. Yeah, let me say one other thing. It's not a panacea. You know, it's another therapy approach in our toolbox that we can use. It's not like every patient that walks in, this is what we do. Okay. Yeah. I can more than not, we will actually introduce that exercise program to lay a physiologic foundation to help rebalance the 3 subsystems of respiration, phonation, and resonance. Okay. We will do that, but it doesn't mean that that's all that we do. Okay.
Yes, that is leading me to several questions, but I'm going to try to ask just one right now. So I really appreciate the fact that you're doing research in healthy voice populations, because I think the implication is that some of the things that you're learning there, maybe voice teachers need to know about. You know, that research actually applies to all of us, not just the medical world. So can you speak to that particular issue?
Let me say something about that. I'm one that believes that every voice, my voice, your voice, every voice can be enhanced for efficiency. Okay, it's just like every bicep can become stronger if the appropriate exercise, the appropriate repetitions, the appropriate technique is used, your bicep can be enhanced. Okay.
Mm-hmm.
I truly believe that voice is on a bit of a continuum. Okay. That continuum is, we have a disordered voice,
Mm-hmm.
normal voice, and we have the super normal voice. Okay. So you have the professional voice. However, there is a different tolerance for the amount of disorder of each one of those. Okay. For
True.
example, if I'm working on the line at the automobile factory, my voice production is not going to have much of an effect on my job. Okay. Unless I happen to be a supervisor and I have to talk to people. And if I'm very dysphonic and there's noise in the background, they may have difficulty hearing me. But just say for argument's sake, very little vocal need. Okay. But then you'll have your people who are maybe professional people, speech language pathologists, physicians, lawyers, preachers, a little bit of dysphonia will be an annoyance, but won't necessarily threaten my profession. But then you have the person who is the professional voice user, okay? And you could take it clear up to the elite professional. The tolerance for a disorder is going to be very different in the elite professional compared to the other working people that I just now mentioned, okay? So consequently, we have to look at this continuum and decide where does the person fit and how acute is this problem. Does that make sense?
Yep. Yep. Yeah, exactly. So then the question becomes, how can voice teachers become more informed and start to get into some of this research that you're doing and start thinking of, in those ways to be able to help their clients and their students? Does that make sense? Like, that may be convoluted, but I'm thinking about how important it is to start having evidence-based practice in the teaching profession as well. And so I feel like the teaching profession is behind where, you know, the voice therapy profession is, where you're starting to parse out different things that you're doing and being able to categorize them. And you write a lot about that, you know.
Well, lots of different philosophies of teaching, and I respect each and every one. And when I talk about teaching singing, for example, lots of different philosophies. Some people are just so intuitive, and you know, as teachers, so intuitive, and they hear and they see, and really can parse out what's going on and give auditory and verbal instructions that really resonate. And the more you have, the easier it is to get one that's going to resonate with your student. Okay. Others are a little bit more science-based, but also have intuition as well, and will actually do measurements and try to determine, you know, precisely what's going on in the voice difficulty. So you have kind of the, if you go from one extreme to the other, you have two schools of thought there. I think it's the blend that really needs to work. When you think about how a person is producing voice as a singer, let's take a young singer, 18-year-old college freshman, maybe has had voice lessons through high school, maybe not, but has just a precocious voice, just very, very talented yet not developed kind of voice. And they begin with their new teacher at the university, conservatory, wherever it happens to be, and there's an airiness, a breathiness to the voice. Well, the question is that a pathological problem? Is it a technique problem? Or is it a maturity problem? So obviously, being in the business that I'm in, I believe it needs to be checked out. And you can send them to a voice center where they are screened. You take a look at the vocal folds, you watch them functioning, you do the measures that are necessary, and you can tell, is there larger than normal posterior gap, which is in the vocal folds, which is not unusual in an 18-year-old undeveloped voice. Is there some kind of pathology that is contributing to the breathiness? Or does it simply appear to be a technique problem? Okay. If it's immaturity, certainly with maturation, they'll get better, but technique can help with maturation as well, especially if a lot of semi-occlusion is going on in the vocal leads that they do, and strengthening and balancing the system. Okay.
Mm-hmm.
So I think the more science background that a person gets, the better. No matter whether it's a speech language pathologist or somebody who is singing, teaching, or somebody who's in the theater world teaching voice, okay? A bit of science and understanding of how the mechanism works and how to develop the system becomes very important. So a lot of our research has been done in the normal voice for two reasons. Number one, we all can enhance the voice, and so it's valid. The original vocal function exercises were done with normal voices before we even got into the pathological voices. And number two, you cannot withhold treatment from patients. Okay, so if I get patients that come in, I can do a vocal function exercise program, but I have to do it as it's been proven to work. Okay, I can't take pieces of it out. However, in volunteer, normal voicing people, I can manipulate it any way that I want to. Okay,
Mm-hmm.
now, do we eventually need to then take what we're learning from the normal voice and apply it to the disordered voice? Absolutely. And that will be one of our next steps as we move forward.
Okay, great. Great. And you've written a lot about categorizing voice therapy protocols. Can you speak a little bit about those categories and why they're important?
Yeah, I call them orientations of voice therapy. First of all, I think speech language pathologists have to be well versed in all of the orientations, because one of the orientations that I talk about is eclectic therapy, and that's what we do. Okay, the interesting thing about that is we have a lot of evidence-based therapies. Okay, resonant voice therapy, manual techniques, Lee Silverman voice therapy, vocal function exercises. I mean, I can go on and on. We have lots of evidence, pre-post evidence that demonstrates they do something positive for the voice. The problem is those are all done under, I'll call it clinical laboratory conditions. We know done in that way, they work. They do something that they're meant to do. The reality is we then combine those with other management techniques, whether it be vocal hygiene, whether it be combining vocal function exercises and resonant voice therapy, combining resonant voice therapy with there's conversational therapy, which is a new kind of therapy that is being introduced now out of Pittsburgh. The minute we combine those, it's no longer evidence-based. Okay? Think about it. So we have a lot of research to do. However, to get back to your original question, I think just the reason I put it into orientations, and the orientations certainly overlap, is for teaching purposes more than anything. When I left my clinical practice and went to the University of Kentucky, I felt the need to categorize things for students. And orientations of voice therapy is how I decided to describe it. And so those orientations are hygienic voice therapy, for example, which is vocal hygiene therapy, is something that has been going on and on and on ever since the very beginnings of the profession. I go back to the first editions of Van Riper and the first edition of West Kennedy and Carr. Those are the first books in the middle 1930s that actually started talking specifically about it, enhancing voice, okay, improving disorders and enhancing normal voice. And by the way, most of our therapy, original therapy techniques, came out of enhancing the normal voice, okay, public speaking, debate voice, drama voice, that type of thing. So they talked about ways of keeping the voice healthy, and it was a lot of don't shout, don't cough, don't clear your throat, don't smoke, a lot of the don't do kinds of therapies. There's some do things as well. Drink plenty of liquids. Okay, warm up and cool down the voice. That's hygiene kinds of things as well. The evidence for using hygiene alone, if you look at the research, the evidence for hygiene as a standalone therapy is not very good. Okay, because people love the information that they get. They think it's very interesting, but they don't necessarily follow it. So you have to actually, if you're going to do it as a primary therapy, you really have to come up with some way of keeping the patient accountable, okay, and keeping them interested in thinking about it. It's the same about thinking how you're talking. In vocal hygiene, you've got to think about all of these good things that you should be doing on a daily basis, and people don't necessarily do it. However, in some research that Nelson Roy did, he demonstrated that people that were given hygiene information didn't get worse. So it may insulate them a little bit, but by having it in the back of their mind that maybe they shouldn't be shouting or clearing their throat as much, etc. Another orientation has been the symptomatic approach to voice therapy. Dan Boone just did a beautiful job in the early 1970s, the first edition of his book, 1971, where he talked about voice facilitating techniques, a symptomatic approach to voice therapy. He talked about listening to how the patient sounded, trying to determine whether the voice that they're giving you is their optimum voice, or is their habitual voice, as he called it, not optimum. And then probing and trying to see, can you use one of these techniques to get an optimum voice from them? And that's where, if you're hearing them use a particular component of voicing, either their loudness, their pitch, the various qualities that people use, their resonance, is there something that you can zero in on that particular function of voice and apply a facilitating technique to change it, okay? It does require that you really listen to how you're talking on a daily basis. He talks about setting up a speech time or a voice time at home to do it. So if people are sitting down at dinner together, that's your speech time. You're really going to pay attention. And for some people, especially if that component of voice is the primary cause of their voice problem. I give the example of, I had a young man who graduated from college, was put in charge of, in a particular business, of 4 other people in a department. They were all older than he was. He was not very confident in himself, so he started using a pseudo-authoritative voice. Well, that was causing his voice problem. That was a symptom causing his voice problem. Okay, so you had to do something to change that symptom. In that regard, symptomatic approach, I think, works very nicely, and there are lots of techniques that you can use to change that. Okay, beyond the symptomatic approach, sometimes I talk about or a symptomatic orientation. I talk about a psychogenic orientation, where you're really concerned more about how is a person feeling. Okay, physically, how are they feeling emotionally, what's going on in their life that can be contributing, for example, to a muscle tension dysphonia, whether it be primary or even a secondary muscle tension dysphonia. Can we talk about their life? Can we perhaps have some counseling, either with the speech language pathologist or somebody who's truly trained in psychological counseling, that will take the tension and stress off of their daily lives, that automatically improves the voice. Okay, Arnold Aronson talked so much in the 1980s and 1990s about the relationship between how we feel and how we sound. We can actually go way back into ancient times, where Aristotle talked about the quality of voice is an indicator of the physical health of a person, so at any rate, it involves more patient interview and counseling and making them aware of the relationship between how we feel, okay, and what's going physically and emotionally, and what's going on with the voice. And then what we have grown to call a physiologic approach to voice therapy, an orientation of physiologic orientation. And that's with the understanding that normal voicing is dependent upon a relative balance of respiration, phonation, and resonance. Okay? Articulation is a part of resonance, by the way. But if there's something wrong with any one of those subsystems of voice production, the other two tend to adjust to compensate. Okay, so let's say that I have vocal nodules. Since I have vocal nodules, I'm not getting total closure of the vocal folds. So I have an air leak. If I have an air leak, I have to build up greater subglottic air pressure. Airflow is much greater between the vocal folds unless I'm hyperfunctioning, okay, on top of it. So respiratory system is working maybe doubly hard. I'm creating tension above the level of the vocal folds, which is changing my resonance. So what we have to do is we have to rebalance that. And that's where I thought vocal function exercises came into play, because if we look at redeveloping the underlying physiology of the voice production, okay, through exercise, through physical exercise that is not speech-based. That, by the way, is one of the criticisms of vocal function exercises. It's not speech-based, okay? However, I go back to the number 29, okay? 29 outcome studies say they do something, okay?
Right.
At any rate, so you develop, you know, as a foundational exercise, as a developmental exercise, you develop the rebalancing of respiration, phonation, and resonance. So I may have somebody that after a couple of weeks of vocal function exercises are going from oh to ooh, and it's really sounded very nice. And then they look at me and they say, how was that? Okay, because what they're developing is not over necessarily to speech, okay?
Right.
And that's the fact, and I immediately add a resonance component to it, a speech-based resonance component, okay? Often, I don't need to do that. You get a natural carryover. But equally as often, I'll give a speech-based thing to hurry things along and make sure that they are developing the carryover that's necessary to make this be an effective therapy, okay?
Yep.
So we talked about hygienic, talked about symptomatic, psychogenic, physiologic, and then what we truly do is the eclectic orientation, which is we take pieces from each one of those, and that's what voice therapy is all about at this point.
Yeah, that sounds like voice teaching to me.
Oh yeah, no question.
It's very exciting to read about that, because I'm hoping that the voice profession, the voice teaching profession, can head in that direction at some point in time and use that. It's just helpful to categorize it and talk about it that way, because until I was introduced to the difference between singing style and function, it was very hard to determine what was going on and how things were working. And as soon as I start working on function, I've noticed that it puts a lot of people at ease, because then we don't have to worry about them singing well, just like work on how the voice is working. It's like exercise, like going to the gym. Everybody can relax. You know, it's a nice way to talk about it with clients too. And it also gives us something to do.
I just believe the more you know and understand about the underlying physiology of voice production, the more you can actually sit there, look at, and listen to someone and picture what's going on. And if you can picture what's going on, you can help shape how the person is producing the voice.
Yeah, exactly. So you've had a front row seat at the burgeoning of this field and the evolution of this whole voice science realm.
Oh, that's true.
Well, no, I'm just saying, it's just what an amazing place to be career-wise. Just watch it unfold before your eyes. What has that been like?
Oh, yeah, I was so lucky. I came along in the profession at a time that has been so very exciting and continues to be. When I think about where we started in voice therapy, we didn't have instrumentation because desktop computers, okay? I tell a story, I'm sure other people have heard this before, but I started my private practice in 1981, I believe it was. And in 19 83, uh, was still struggling to make it in a private practice, which back in those days, we didn't have speech pathology, very many speech pathology private practices. And that was before I joined Sawyer and Associates. And so in 1983, ASHA was supposed to be in New Orleans. And it was that year that we were trying to pass the Women's Rights Amendment. And Louisiana didn't pass it. Mm. And so ASHA pulled out at almost the last minute and moved. Well, I was still struggling to make it, and I couldn't afford to go to New Orleans, and so I wasn't going to ASHA that year. But where did they move it? They moved it to Cincinnati, okay?
Right.
And obviously, I could go to ASHA then. And that was the year that Diane Bless and Manura Hirano and an otolaryngologist from California, Robert Fader, presented 2 short courses. One was on laryngeal video stroboscopy, and one was on acoustic analysis of voice. And those were the first workshops that were given at the national conference. And those things, those procedures were not being done anywhere except university-based programs that could afford the instrumentation and the research necessary to do it. And that actually is where I say my career truly started, because those short courses turned me on so much. I got so excited about it that I called Dr. Bless right after. She invited me to Wisconsin and actually gave an entire week of her time teaching me how to do these things, teaching me how to put together a voice center. And less than a year later, we had the Institute for Voice Analysis and Rehabilitation in Dayton, Ohio, set up and ready to go. And so I really look at Diane as my mentor and intellectual benefactor when it comes to actually jump-starting the career.
That's incredible. That's worth the entire interview right there to get that on tape, just to talk about that.
Very, very true. I'm so indebted to her.
That's huge. That's really huge. Where do you see the field of voice therapy going, or voice science going, I should say?
I think we need to be able to more specifically diagnose precisely what a person is doing, okay? We know that voice production is this balance in the 3 subsystems, but what is that balance? Is it the same in each individual? So if everybody who has vocal, take everybody who has vocal nodules, do they all use the same strategy to produce voice? No, they don't. Okay, we know that for a fact. Some hyperfunction, some give up the ghost and hypofunction. So we're not really treating nodules, we're treating the person's response to the nodules. If we could actually come up with a way of easily measuring the relationship of those 3 subsystems, let's give respiration a 1, phonation a 1, and resonance a 1, okay? So the equal balance among the 3, it's 1, 1, 1, let's say. But let's say now I have those nodules, and so I'm hyper-functioning, and suddenly I have a 2 in respiration, okay? A 0.5 in phonation, okay? And a 2 in resonance. Do you see what I'm saying? Mm-hmm. All hypothetical at this point, but actually one of my former doctoral students, Dan Croak, is working on this research and has 2 articles in Journal Speech Language Hearing Research that's describing the differences in even normal voice of how people produce voice. And the question that we had is, are there infinite ways people can combine these 3 subsystems, or are there limited ways that people do combine these 3 subsystems? And if you look at his article, again, it's Dan Croak, C-R-O-A-K-E, JSLHR. If you look at what people with normal voicing are doing, They fall into basically either primarily respiratory driven voices. They're all driven by the respiration system, but when you look at the various measures that you take, are they primarily respiratory? Are they primarily laryngeal? Or are they primarily resonance? And that's what they're falling into, is these categories. So if we can identify precisely what a person's strategy is, can we actually pinpoint the precise kind of therapy that we should be doing, rather than what we do, which is we throw the book at them. We do a little bit of everything in voice therapy. We use all the orientations. Okay, can we be more precise? So one of the things I'd like to see happen is a more precision-driven therapy, a precision-driven approach to how we're treating our patients.
Yeah, you write about that quite a bit, actually, right? Or you've written about that. I've read it. I know I've read it in one of your papers about that's one of the best things that's come out of all of this research, is that we're able to diagnose more quickly and then get to a solution more quickly.
Even in what we're doing right now, because of having stroboscopy or high-speed digital imaging and having the acoustics and aerodynamics, do we have to have that to be good therapists? No, but they certainly can enhance and more quickly help to identify what a person is doing. Now I want to go to the next step, okay?
Yeah.
It's not identify what they're doing, but how are these three things interacting more precisely say what this person is doing, so that I can plan a therapy approach or a management approach, or perhaps do something different therapeutically that we haven't come up with yet in order to enhance that voice production.
Yeah. Okay. That makes sense.
Yeah. There's a whole new area of medicine called precision medicine. Now, a lot of it has to do with looking at the genetics of a person. Why does the one person respond positively to this blood pressure medication, whereas another person doesn't respond to it? And it has to do with the precision, with their genetic makeup, with their lifestyle habits, etc. Voice can be the same thing. Okay, it doesn't necessarily have to be a genetic basis, but it certainly can be lifestyle and habitual basis. Okay, and I think precision medicine in voice therapy has a role.
Okay. Looking back on your career, can you think of you already talked about the point in time where you saw the spectrogram analysis and got to work with Diane Bless and learned about that. Are there any other things that stand out in your career as major jumps forward in the field?
Early on, Hirano's representation of the layers of the vocal folds. I mean, I can remember early in the career, someone would come in with vocal fold cyst. The vocal fold would be stripped, and they would come in after surgery sounding worse than they did before surgery. We didn't have stroboscopy. The physician would take a look with the mirror and say, the vocal fold looks fine, I don't know what's going on, when in fact they obviously had scarred the ever living out of the vocal fold. And then, of course, with our use of a laryngeal video stroboscopy, we could point out and say, look, this is precisely what happened. And so what it did was it actually was major change in the kind of surgical techniques that were utilized and are utilized for patients. Being able to enhance the voice through medialization procedures, through injections, a lot of the medical breakthroughs that have occurred. We didn't have Botox for spasmodic dysphonia, and seeing Botox come along for spasmodic dysphonia. It still would be great if we could come up with other more permanent and consistent treatments for the neurogenic voice disorders. So there have been a lot of things over the years that I think have really advanced the profession.
Wonderful. And just to wrap it up, where are some places that people can find your work, your writings? I know you've written a couple books that are published through Plural Publishing, but are there other resources that you would point people toward if they want to know more about your work career?
Well, we just came out with the next edition of Clinical Voice Pathology Theory and Management. Actually, I just got my copy of it a couple of weeks ago. This has been really the biggest. This is the 6th edition, I think, and it's been the biggest update we've ever done. And as a teaching tool, we now have Plural's Cloud. We have over 100 items in the cloud, including PowerPoints for every single chapter for the instructors.
Wow.
We have over videos. We have videos of Nelson Roy and me doing therapy. We have a new chapter on trachs and vents, because a lot of people who teach voice disorders are asked to teach on trachs and vents. So there's a new chapter in the book on that. Everything now is in color. I'm really proud of this particular edition. And then Edie Hapner and I just completed and it will soon be available within the next 2 weeks, the 5th edition of Voice Therapy Clinical Case Studies. And we have over 54 cases and then a bunch of case vignettes. And it's from the top voice clinicians across the globe who have given just very detailed case studies. I mean, the book is probably over 500 pages at this point, and just has case after case after case of all different kinds of voice disorders, categorized in primary muscle tension dysphonia, secondary muscle tension, neurogenic disorders, glottal incompetence disorders. Just again, another book that we're very proud of. There are also teaching videos of how to do vocal function exercises. We have a form of resonant voice therapy that I call a programmed approach to resonant voice therapy with MedBridge Corporation. And of course, we have some videos with Plural still. They're quite old. I think I don't even recognize myself when I look at the old videos, but they're out there. And then, of course, I'm most proud of the research articles that we have, and they're all over the journals. So.
Okay, great. Would it be okay to put links to some of those things in the bottom of this interview so people have access to them?
I don't see why not.
Okay, great. Yeah, I did find one of your ResearchGate was a website where I found access to a couple of articles where you could download the whole article. So I might pick one of those and put them down for folks. So.
Oh.
Excellent. Well, thank you so much for your time today. I'm really hoping this reaches a lot of people and helps a lot of people, and is a good record of your exhaustive career and all that you've done to help people, and talk about being a light to a lot of therapists and a lot of people like me who don't understand all of this stuff completely. It's really wonderful to get to talk to you. So thank you for your time.
And thank you. It's been a lot of fun.
Absolutely. Bye.
Bye-bye.